Ladies, you can give me 15. I think everybody received these slides already to download. I've pulled a few, so this stack that you see is a little shorter than what you've got in your handout. We're going to talk briefly about managing the obstetrical management at the threshold of viability. And even though this is challenging, because even though it accounts for probably 0.3% or less of all preterm births, it's at least a third of all the morbidity and mortality that we see, perinatal morbidity and mortality that we see among our clientele. Most of the research articles, commentary on how to manage things here and counseling, it discusses 22 to 25 weeks. So basically 22 and 0 to 25 and 6/7 weeks, that's the gestational age range that we're dealing with most papers. The Maternal Fetal Medicine Network, NICHD Maternal Fetal Medicine Network, published a big paper on the care of these really young babies back in 2008. Over 4,000 infants were studied. They all delivered between 22 and 0 and 25 and 6/7 weeks. And they followed the outcome, not only the immediate birth outcome and perinatal period, but all the way to almost 2 years of age. And what we see is about half of those babies didn't live. Most of the deaths occurred very shortly after delivery, but there was still more mortality that occurs beyond 28 days post-delivery. About 2/3 of the babies died or lived with profound compromise, and only about 25% actually were, quote, intact. So depending on your practice environment, there are a number of questions that you'll face, sort of the nitty-gritty questions that you'll face when a patient rolls in your door. And your decision making will vary a lot based upon the clinical situation. But in general, these are the key questions. Should the patient be transferred? Is there a role for steroids, antibiotics, neuroprotection, or cesarean delivery? So as far as transfer, depends on your practice environment. If you've got a really capable nursery, studies have shown high volume nurseries with lots of experience taking care of babies in the extremely low birth weight range, it's less than 1,000 grams or about 28 weeks, the outcomes will be better than smaller NICUs. And it's best, even better, if the babies are born in those level 3 or level 4 institutions. So the answer to transfer, yes. If you're not in one of those high volume centers, you do want to transfer the mother, you want an in utero transfer. And where I am, every now and then it comes up that we've got a referring center that's anxious to transfer a patient. And of course the question is she stable? And again, you'll have to use your clinical judgment here. In general, I think when you're in that sticky situation, is mom going to be in trouble? If mom's hemorrhaging or septic and unstable, it's probably better to keep her where she is if you can get the intensive care that she needs there. On the other hand, if it's a fairly advanced gestational age, say 25 plus weeks gestation, mom is stable, then you've got to ask yourself, will the baby deliver between your hospital and the receiving institution? Where I am, we have what's called the baby buggy, and in a lot of instances, we actually send an ambulance with a neonatologist and some of the initial stabilization equipment and isolate to the institution, and then make a judgment from there. A lot of times, an obstetrician will go too, and the patient will be checked, condition will be evaluated. A decision is made to either manage it there or bring the patient to us. What about corticosteroids? You probably know all this already. Corticosteroids have been around since 1976 or so, the first studies by Liggins and Howie, New Zealand investigators. And if the patient's 24 weeks gestation or greater and delivery is imminent, it will happen in the near future, almost always the answer is yes, go ahead and give steroids. The evidence for steroids at 24 weeks and beyond is very good. Prospective randomized trials to show that there's decreased intraventricular hemorrhage, increased survival, perhaps decreased necrotizing enterocolitis, as well as retrospective studies to support its use at this gestational age. But what about 23 weeks gestation? Now, quite a bit of retrospective data to suggest that steroids administered at 23 weeks, you get those on board, the baby's chance of survival is higher. The problem with retrospective studies is that there may be other clinical variables that influence the ultimate outcome also. So we don't, when a patient comes in, we don't give steroids to every single patient at 23 weeks gestation. We consider it. There's lots of counseling, depends on if mom and dad are going to opt for resuscitation or not, and also it also depends on how stable the patient is. But at 23 weeks, I'd say the answer is maybe. Depends on your counseling and clinical situation. And generally, at 22 weeks gestation, the answer is no, generally. There are some exceptions. Antibiotics, I can cover that pretty quickly. For the most part, you use antibiotics for the standard obstetrical indications. If the patient's got pre-prom, antibiotics are used to extend the latency period. If you're anticipating a vaginal delivery, again, delivery is imminent. Preterm babies will benefit from antibiotics. It will reduce the chance for group B strep sepsis. So those are your indications. If the patient, let's say, is advanced dilation or a very favorable cervix, and she's 25 and a half weeks, and for whatever reason you'll be inducing, perhaps it's a maternal complication and an induction is required, then you'll give antibiotics for that situation. But if it's a situation like placenta previa or abruption, severe preeclampsia, where the patient may deliver by cesarean section, you don't necessarily have to give antepartum antibiotics. Your prophylactic antibiotics will probably cover group B strep, but the baby is less likely to be infected in those clinical scenarios. How about neuroprotection? You're probably familiar with this committee opinion that came out in 2010. It was reaffirmed in 2016. The author was, ACOG and Dwight Rouse was the lead author. These are on the table. You'll see 3 prospective randomized trials of magnesium sulfate to decrease the chance for cerebral palsy. And these studies, Crowther, I believe, was an Australian study, Merritt, French study, Rouse, a US study. And alone, none of them showed a decrease in cerebral palsy, but a systematic review and meta-analysis did show that antepartum magnesium sulfate does reduce the likelihood of cerebral palsy. So you use your institution, if your institution uses, the committee opinion says, if your institution uses magnesium sulfate for neuroprotection, you should have a protocol or a policy. I think now almost all MFM centers have a policy for using magnesium sulfate, and it can be anything from just a single 4-gram load, perhaps, to a 6-gram load, 2-gram infusion for up to 12 hours. So most of these studies, if you really look at the table, only the study at the bottom, we can see that the neonates were the pregnancies were 24 weeks gestation up to 31 weeks gestation. So we don't really know. It didn't include 22-weekers and 23-weekers. The other 2 studies, if you read the paper, it says less than 33 weeks or less than 30 weeks, but it's hard to determine how many pregnancies they had that were really at that 24, 23, 22-week gestational age. If given properly, the risk associated with magnesium sulfate is minimal, and so I think the answer for these is if delivery is imminent and you're in the 22 to 25 week range, you want to give magnesium sulfate. And one question that we wrestle with, I'm asked, it seems like 3 times a week from the doctors I work with is, well, she had magnesium sulfate 3 days ago, and I think she's going to deliver now. Does she need magnesium sulfate again? And the answer is, if it's 3 days ago, it's yes. We had a nice paper here. Dr. Turret's in her group, almost 1,000 babies were. It was a secondary analysis from the original Rouse trial, and basically they found ultimately cerebral palsy risk was lower if the infants delivered within 12 hours of their magnesium sulfate dosing. So if the magnesium that you originally gave was stopped more than 12 hours ago, you definitely want to give them some more magnesium sulfate based on this study. What about 6 hours? We don't know. It hasn't been studied, but I'd say if it's been within 12 hours, we don't repeat it. If it's greater than 12 hours, we do repeat it. And then finally, what about cesarean delivery? This is a study that was an oral presentation at the, I think back then it might have been Society of Perinatal Obstetricians, not Society of Maternal Fetal Medicine. Dr. Bottoms presented the oral presentation then. And basically, it investigated the treating team's notion of whether the pregnancy was viable and their willingness to do a cesarean section and how that affected outcomes. 700 infants. Now these were all extremely low birth weight, so less than 1,000 grams. But the gestational age range was fairly broad, as young as 21 weeks, as high as 30 weeks. Turns out they had about 270 roughly infants were in the limits of viability range, so 25 and 6 or less. But his study, when he evaluated it, what they showed was, and what they did was review medical records and looked at notes to determine what the team's assessment was before the delivery actually happened. It was a retrospective review of the charts. And what they found was the willingness to do a cesarean section was associated with improved outcomes. And actually, even if a cesarean section wasn't ultimately done. So this really changed our thoughts about how to approach some of these very early pregnancies. However, this was a retrospective evaluation, and there's nothing here that clearly tells us there's cause and effect. It was an association. If the treating team thought the baby was going to do relatively well and they're willing to do a cesarean section, the baby did well. However, there may have been a number of things that ultimately contributed to the baby's doing well or not. So, for example, if a mom comes in and she's had ruptured membranes in 16 weeks and hydramnios the entire time, and she comes in at 23 weeks with a fever and abdominal tenderness and abnormal heart rate tracing, that is a very poor prognostic situation. Another baby with the same gestational age, same weight, perhaps cervical insufficiency with hourglassing membranes might be managed differently. But at any rate, this really caused us to be a lot more liberal about doing C-sections at earlier gestational age, just because there was some fairly compelling information here. Even in that study, when we look at 24 weeks gestation, the pie chart on the left shows that the pie chart on the left is 24 weeks gestation. The babies that were managed by a treatment team that was unwilling to do a cesarean section. And you see that 2 out of 3 of those babies, there was a neonatal death. You had 5% were stillborn and intrapartum death, and 13% intact survival. The pie chart on the right were the babies managed when the team was willing to do a cesarean section. The neonatal death rate, instead of 63%, was 44%. You had no stillbirths, no intrapartum deaths, but the intact survival still only about 17%, not statistically different. So what do you do about a cesarean section at the threshold of viability? What the guidelines generally say, do a C-section for all of the usual indications. That would include malpresentation, abnormal heart rate tracing, previous uterine scar. Again, at the very early gestational ages, 23 weeks, 22 weeks, it may be appropriate not to proceed with C-section if the parents are not wanting to be aggressive. I have breech in yellow because I think perhaps maybe for some of the practicing MFMs and OBs who have a little bit more gray hair, we would have had a chance to do breech deliveries in term pregnancies before. This is an interesting article, Green Journal, published in 2002, and this group had, I think it was a series of about 6 to 9 deliveries at very early gestational age. They actually did vaginal breech deliveries, but they did the deliveries in cull, so the baby was protected. If the sac is not ruptured and it begins to protrude down through the introitus, the baby's very small. Often the head is already at or below the level of the cervix, and because the baby's surrounded by fluid in a gestational sac, the chance for head entrapment is very, very low. I've had a number of deliveries in my career where it's been managed this way. So a good example might be the patient, again, who comes in with cervical insufficiency, membranes are ballooning into the vagina, she's in Trendelenburg, you're trying to do everything you can to extend that pregnancy, but she has bleeding or pain, and when you do an assessment, you do your bedside ultrasound, you can see that the baby is halfway through the cervix. For this scenario, depending on gestational age, again, 22, 23 weeks, I would try to, it's a process to it. They describe giving tocolytics, but really gentle fundal massage to determine if the amnion advances. You don't want to go in and push really hard because you'll rupture the amnion, but gentle fundal massage. If the amnion advances with that alone, then basically you can get the entire sac, amnion out, the baby within, rupture it, and move from there. In fact, there have been a couple of patients where, what do you do if it ruptures? Well, that can be scary. Again, it all depends on how well advanced the body is when you start. I've had a couple of occasions where I've actually coordinated with the anesthesiologist and gotten the patient under general anesthesia, intubated before I started the fundal massage process. Probably want to be in a place where you've got plenty of help. If things go wrong, you usually have to have an assistant to help you down below if you're doing the fundal massage, or vice versa. So I think that covers most of what I wanted to discuss. Clinical variables. Most of you are probably aware of the NICHD Extreme Prematurity Calculator. If you Google NICHD Extreme Preterm Birth Outcome Calculator, then you'll go to the website, and there are a number of clinical variables that will influence the likelihood of survival, intact survival. The estimated weight, gestational age, whether the neonate was exposed to antenatal steroids, whether it's a multiple gestation, and gender, all can influence the likelihood of having a good outcome. And so clearly the site says this is just a tool for general general education. It isn't good for predicting how each individual baby will do, but if you're struggling with this, putting all the clinical variables together, this can help. One of the key challenges I find is the patient comes in and it's a multidisciplinary team managing and counseling. MFM, OB, neonatal. In this particular example, it's a 22-week gestation. The estimated fetal weight for the baby is 475 grams. We don't know what the baby really is going to weigh, but the best we can tell is 475 grams. Female, singleton, steroids on board. And so what are your outcomes? The column on the left, outcomes for all infants, really represents the likelihood of having survival, intact survival, for every woman that comes into labor and delivery in that situation. Whereas the column on the right, outcomes for mechanically ventilated infants, really reflects there are going to be some instances where the family and the treatment team decide not to intervene. And so maybe there's an antepartum stillbirth or an intrapartum stillbirth or a decision not to resuscitate because the baby is very, very young with maybe translucent skin, infused eyes, and unexpectedly small. Those are all filtered out, and the column on the right is if the baby makes it to the nursery and survives long enough to be mechanically ventilated. And those are the statistics that the neonatologist tends to quote. And you can see there's a pretty big difference here, 8% versus 23%. It takes some time for the patients to sort of grasp these concepts. Each patient is going to see this differently, but I think it's critically important to explain the differences and then ultimately, hopefully there's a time for the patients to sort of reflect on it. We go back in and ask follow-up questions and then go from there. If the patient's undelivered for a while, pretty much every so many days, you've got to go in there and reassess and repeat your counseling. I think that I went through that pretty quickly, but those are the highlights I wanted here today. Again, your slides have a little bit more information, and I'm happy to answer questions at the end.